Okay, peeps. We're here today to do a review for the musculoskeletal exam number 9, due next Monday, 8 a.m. Be there, be square. Okay, let's start off with our different definitions that we want to make sure that we're familiar with, and it shouldn't be too hard in memorizing this because this was learned clear back as a CNA. So first of all, we want to know what flexion is. Flexion is the action of bending a limb or a joint. Extension is unbending the movement around that joint. Pronation is the rotation of the hand and the forearm so that the palm faces downward. Supination is rotation of the hand and the forearm so that the palm faces upward. And abduction is moving the extremity laterally from a neutral position at the side of the body to a position at the side of the body. Oh, that makes a lot of sense, doesn't it? So abduction is that you're taking it away, from the body. Adduction is where you're bringing it towards the body. We're adding it to the body. Abduction is away. Amber alert, my right arm is missing. Internal rotation, of course, is where the joint is rotating in a circular motion, and it can go internal or external when we're speaking of the shoulder. So the thing about it is that just when you see a definition, you need to be able to recognize what term is used to describe that motion. We also talked a little bit about assessing pain, and we in the nursing program utilize the numeric pain scales, but there are a lot of different pain scales that you can utilize. We talked about FLAC. I think you talked about that maybe in fundamentals. But just be familiar with Caldera and some of the verbiage that's used. For example, I think Chantel was talking about the PQRS pain scale. It's actually PQRSTU, but they use the words the quality of the pain instead of C for characteristics, and they use the words provocative for exacerbation or relief. They use the word palliative. So just be aware of the different terminologies that are sometimes used for Caldera, and they basically all mean the same thing. It's just different verbiage that's used. Okay, so we need to remember when we do neurovascular checks. So anytime that there is a disruption in the integrity of the musculoskeletal system, then we need to do a neurovascular check. We sometimes call that orthopedics, but for orthopedic patients, whether it's surgery or an injury, we need to do a neurovascular check. And so the components, what are the components of a neurovascular check? Waiting. Oh yeah, nobody's here. You're all in the farm. Anyway, so the components of the neurovascular check is number 1. C is going to be circulation. So you assess pulses, you assess capillary refill, you assess temperature. You assess edema, and you assess a skin color. So those are the signs of circulation. Those are the signs of perfusion. Circulation, perfusion are often used simultaneously. So just recognize that you're assessing those things. But I think in the example of the question I gave you in lecture, I said, so what is the sensory assessment? How does the nurse assess the sensory component of the neurovascular check? So just be sure as a testing strategy that you look at the adjective of neurovascular. Is it circulation? Is it motor, or is it sensory? Because that will tell you what the option is going to be that you want to choose. So I think I threw out this question too. So if you have had surgery, if your patient has had surgery on the lumbar spine, where are you going to assess CMS? We're actually going to do it in bilateral lower extremities. So anything lower than the lumbar spine. I didn't really mention this yesterday, but in when we looked at that little diagram of on the slides, it's the first slide of the spine and the curvature of the spine. And we talked about the cervical vertebrae and the thoracic vertebrae and the lumbar vertebrae, the sacral vertebrae and the coccyx vertebrae, and then the coxae, I guess is what they call it. But the thing about it is that when there has been an injury at any one of those levels of vertebrae, then to the spinal cord, then basically everything below that point is going to be affected. So just kind of remember that as an overall rule for how is the injury going to manifest itself. All right, so what do you think the signs and symptoms are going to be of somebody that has a cervical neck injury? And that's not worded correctly because I'm looking at the answers and that's not worded correctly. So what kind of injury are you going to have if you have a cervical neck injury? And it doesn't really matter if it's cervical or if it's lumbar, if it's thoracic, although we don't have many thoracic injuries because that area of the spine bends the least in a lifetime. But what are the kinds of causes? What is the etiology of injury or pain for cervical neck injuries? And we've named them. It's the same for cervical. It can be the same for lumbar. So you have muscle strain or sprain, ligament strain or sprain, or we have a disc degeneration or herniation. So there's three causes for any kind of pain to the spinal area. So with muscle strain, you're going to have severe pain on movement. Remember, we talked about that being the buildup of lactic acid in the muscles, and the way you resolve that is through movement and through the flushing of intake, increasing your fluid intake, because we want to flush that lactic acid out of the system. If we have a ligament sprain, it's a little bit more serious than it is with a muscle strain, because the ligament is supporting the bony structures. And what is within the bony structures of the spine? The spinal cord. So if there is the possibility of one of those vertebrae shifting and putting either pressure on the spinal cord or injuring it, tearing it, bruising it, that type of thing, then the pain and the prognosis is much more severe. So what we want to do with someone that has a ligament sprain is they're going to have a very unstable sprain, so we're going to brace the area. If they have it in the cervical region, we're going to put them in a neck brace, and we're going to keep it there. If it's severe, where there's a possibility of where a vertebrae has broken, then we'll put them in a neck brace. But we have to support the bony structures to what the ligament is attached to. And then we have either disc degeneration or herniation. And this will always put some kind of pressure on the spinal cord itself, or immediately on the first nerve root that comes out of that portion of the spine. So there's going to be numbness and tingling of the extremities. The pain is going to be so severe that it interrupts sleep. It can cause a headache. It can cause pain when you're moving the neck, and that pain can radiate down to the shoulder and down the arm. So when the pain becomes severe like that, we know that there has been some kind of disruption in the hernia or in the disc between the vertebrae, or the vertebrae themselves are starting to crumble or break just randomly, and put pressure on the spinal cord, which is going to cause that nerve paresthesia. So remember that when there's paresthesia or numbness and tingling, that a nerve is involved. All right, so what are we going to do for interventions for somebody that has cervical neck pain? And this is true for no matter what the cause is. First of all, we're going to do strength building exercises for the muscles that surround the spinal column. So you'll have strengthening exercises, and then we'll remind them about having proper body alignment and using body mechanics. Now, if it's so severe that there needs to be cervical intervention, then we're going to do an ACDF is what it should be. That's anterior cervical discectomy and fusion. Or there will be a minimally invasive surgery, which is usually a one-day surgery, an ambulatory surgery, where they leave the same day that they come. So what are we going to do? If a person has had such a severe injury that they've had an ACDF, what are we going to do? First of all, post-operatively, we assess the airway, breathing, and circulation. That's always the number one answer for that. You want to check for bleeding and drainage. Now remember, we talked about dependent drainage with this type of surgery, because the person will come out of surgery and be in a supine position. We want to check the person's swallowing ability. We want to monitor vital signs. We want to monitor their neurological status frequently. We want to monitor for any hoarseness in case there's been some laryngeal injury because of the intubation. Or because of edema, swelling after post-operative surgery, after they don't have the ET tube anymore, then there may be some edema that accumulates there. We want to assess the patient's ability to void. Remember, if they have an injury to the spinal cord, everything below that cervical, which is the higher vertebrae, the first 7 vertebrae of the spine, anything below that is going to be effective. So first of all, they've been under general anesthesia, but also if they can't void, then there is maybe a concern that there has been some damage done there to the spinal cord. We want to monitor their intake and output. We want to manage their pain, and we want to assist the patient with ambulation within a few hours surgery, if it at all possible. So we're going to have to do some discharge teaching as a nurse post-operatively. So one of the first things that we need to tell them is that we need to have somebody stand with this patient for the first couple of days after swelling, because of the potential of edema that will compromise the airway. We want to keep the incision clean and dry, and we want to tell them how to do that. We want to monitor for swelling, and of course, maintain the airway is going to be the number one priority intervention. We will review their drug therapy with them, recognize that a few days, maybe it's not a few days, it's like within 24 hours, they may have been on opioids for a long period, month and a half prior to surgery. And so when they wake up, there may be an expectation there that the pain will be totally gone. But again, these are nerves that we're dealing with. So there may be some nerves and some tingling and numbness for a short period of time after the surgery, but after 24 hours, that pain should be resolved. We want to review activity restrictions with them. So we don't want them to be doing any lifting. Remember, this is your back, and anytime you do lifting, your back is involved. The back muscles are involved in that. We don't want to drive with them under unless the physician has given them permission because of their inability, their impaired mobility, and their being on strong analgesics. We don't want them to do any strenuous activity so the back can heal. We encourage them to walk every day, and we want them to wear a brace per the surgeon's prescription. So again, we will call the doctor if numbness and tingling gets worse, or if their swallowing becomes difficult or they develop a hoarseness. Again, there's some inflammation going there that we need to protect the airway, so we will call the doctor immediately. So what is the pathophysiology of a herniated disc? Herniation of the nucleus causes compression of the spinal nerve. So what happens here is that little gel-like substance. Remember the picture, go back to the slides and look at the little picture of the slides, because it compresses, that gel-like substance will come out and compress or put pressure on the spinal nerve, which will cause pain. Just really, really a deep, deep pain. So the number one thing that we can do for our patients is to teach them some preventative care. So the preventative measures that we want to take for low back pain is using body mechanics, using good posture, avoiding prolonged sitting or standing, getting assistance with household chores and other activities if it's needed. They need to participate in a regular exercise program that strengthens back muscles, and they don't need to wear any more high heels. Oh, sorry. And then they need to maintain an ideal weight and stop smoking. Okay, so also other things that you can do to reduce back pain if you already have it is, take off some weight and get down to your ideal body weight. Wear very comfortable low-heeled shoes. We want to use a firm mattress that provides adequate support, and we want to do low-impact exercises such as swimming. Now, we talked about upper back pain or cervical back pain. Now let's talk about lumbar back pain or lower back pain. So what are the causes for that? It's the very same as it was for cervical back pain. It's going to be your muscle strain or sprain, your ligament strain or sprain, or it's going to be vertebrae degeneration or disc degeneration or herniation. Okay, so what are the signs and symptoms of that going to be? Well, it's going to be continuous pain, duh. It's going to impair your movement because it hurts when you use those muscles to reposition yourself. And they may be sciatic nerve involvement. So if there is sciatic nerve involvement, which will manifest itself by numbness and tingling, and it could be asymmetrical, so it doesn't have to be bilateral. So if we had those signs and symptoms, are we going to have a disc degeneration or herniation or a ligament strain or sprain, or have we just pulled a muscle in the back? There's nerve involvement. So if there's nerve involvement, it's going to involve the disc. So that is kind of a little point that you want to remember, because when a person comes in and they're describing their back pain, then you will have a higher suspicion that the likelihood involves the disc rather than being a ligament or muscle strain or sprain. So, interventions that a patient can do or the nurse will perform for someone with low back pain is positioning. We need them to be in a comfortable position and in good body alignment. They need to be on a firm mattress. They need to be on medications for pain and maybe some anti-inflammatories. We want them to do heat therapy. We want to have them, again, do strengthening exercises. We do want them stomach lying because it is more likely to put the back in a proper body alignment. And then we want to, again, lose weight if needed. So post-operative complications, whereas above for upper nerve or upper spinal problems or surgery, we were wanting to make sure maintain the airway and that type of thing. But now we're in the lumbar spine, so we're going to look for sciatic nerve involvement. Is there any nerve numbness and tingling that is at the site and travels down the leg? If they've had any kind of loss of bowel or bladder control, then we know that there's some kind of injury or swelling that is affecting the spine. So we want to pay close attention to that and would notify the physician if needed. There is going to be the potential for paralysis, so we want to check their reflexes. We want to check their CMS, so to speak, when the person has had lower back surgery. And we want to make sure that their lower extremities are getting perfused. Now, there's some complications that we talked about with post-operative care for someone that has had back surgery. And this could happen with upper or lower surgery, upper or lower spine levels. So there is a possibility, because you're working around the cerebral spinal tract, that you're going to have a cerebral spinal fluid leak. So we want to be looking and assessing the site. Notice, if you'll recall that slide in the lecture, that there was a slight bulging or accumulation of fluid on the anterior aspect of the incision.
You are currently the only person in this conference.
And so that is going to indicate that there may be an accumulation of fluid. There, you may see a little drainage there. It may be serosanguinous looking. We also want to be concerned with fluid volume deficit. If the person has hemorrhaged a lot during surgery or lost a lot of blood, we want to make sure that their bladder is working. So we will assess for acute urinary retention, as that is often not only the case of someone coming out of a general anesthesia, but it is occurring too if there is a nerve in the lower back spine that has been compromised, and therefore the person has lost control of the bladder sphincter. We want to check for a paralytic ileus. We want to check for fat embolism syndrome. Remember, we talked about that. And we want to make sure that there is not persistent or progressive lumbar radiculopathy. Radiculopathy, do we know what that is? That's nerve root pain, really deep root tingling, just miserable pain. And then, of course, we've got to be looking for infection. We're looking for affection. We're assessing for infection. All right, so what are the anatomical structures that are affected by compromised nerve innervation of the lumbar spine? First of all, it's going to be the lower extremities, and it's going to be bowel and bladder control because they sit lower than the lumbar spine. And so if anything in the lumbar spine region has become compromised or injured in any way, then it's going to affect whatever is being innervated, the muscles, the organs below that level. Okay, so let's move on to osteoarthritis. So what are the causes of joint stiffness and pain? And most of the time it's going to be just a loss of cartilage between the bones, and it results in a swelling and stiffness. This is primarily found in the weight-bearing joints of the hips and the knees, but it can be found in the hands and the spine as well. So what are some signs and symptoms of osteoarthritis? Well, there's going to be joint pain and stiffness, of course. It can be unilateral or it can be bilateral. So just keep that in mind as well. And don't forget to know your definitions for Heberton's nodes and Bouchard's nodes. So what do we do? Again, we're going back to preventative medicine here. We want to keep our BMI, body mass index, lower than 30. We want to, I'll tell you why, because this is such a stimulating conversation, isn't it? One person. It's boring to me. Anyway, so BMI less than 30. We want to give our patient information about the medication that they're going to be taking and the side effects of the medication. Again, we want that smoking cessation to be in effect. We don't want them to start or stop smoking. I mean, we do want them to stop. We don't want them to start. Sorry. We want them to avoid high impact exercises and wear supportive shoes. And we encourage the patient to do some patient therapy and occupational therapy. Okay, so what are some non-surgical interventions? I just saw myself in the camera. What are some non-surgical interventions for osteoarthritis? So you're going to have analgesics, of course, NSAIDs, Tylenol, topical drugs, maybe even some opioids. And then you're going to have non-pharmacological interventions that you can do, such as resting the joint, positioning the joint so there's no stress on it, applying heat and cold therapies, and of course, losing weight. All right, so what are some surgical interventions for osteoarthritis? And that would be arthroscopy and joint replacement therapy. All right, we also talked about rheumatoid arthritis. And rheumatoid arthritis manifests itself by having inflammation of the joints. Usually when the person wakes up in the morning, they're already stiff and in pain. It can be bilateral. It can be multiple joints. Remember, the problem with rheumatoid arthritis is that it's a joint, it's a synovial joint problem. So the synovial membrane is affected here, which causes pain in the joint. It'll appear in the upper extremities, in the hands first, and the person can have moderate pain or they can have severe pain. And it can cause deformities. I think you saw that picture in the slides that indicated there's severe deformities of the bone structure, of the skeletal structure. So remember, this is an autoimmune disease, so it's systemic, and there may be a fever, a low-grade fever that is associated with it. The person is going to have extreme fatigue and weakness and anorexia. They may exhibit some weight loss. They may have anemia. There will be lymph node enlargement. But the problem can be that the heart-lung synovial membrane can be involved in this because it's a systemic disease, and therefore you can have inflammation of the membrane, which is going to irritate the tissue, possibly do some destruction there, but it's going to irritate that tissue, whatever it's enveloping in the body. And there will, like I said before, could be bilateral joint involvement. And the fact of the matter is it involves every joint of the body. Okay, so what is functional ability referring to? It's your ADLS. So whenever you see the word functional ability, think back to your activities of daily living. This is how we define a person's quality of life and their functionability. So just think of the ADLs. So what are the rules for assisting with activities of daily living for CNAs or nurses when we stay within the guidelines? Because remember, the goal of any long-term care facility or rehab, SNF unit, anything like that, is to maintain the patient's or the resident's highest level of functioning. It does not mean they're going to have the level of functioning that they had when they were 12, 15, 18 years old. It is what is the highest potential this body at this time in their life can do. And we want to make sure that they always are at that level so that they can maintain their independence as much as possible. However, when we are talking about rheumatoid arthritis, it's so painful and debilitating that you will need to assist the patients when necessary. Use your assist devices, your walkers, your crutches, your canes, whatever you need to do. It may even be a wheelchair that you need. Encourage that independence, though, and the counter medications may be taken as needed. So what are some patient education points you're going to make with somebody that is pre-opting for knee replacement arthroscopy? You are going to teach the person how to ambulate with their assist devices. So this is done both pre-surgically and post-surgically. So pre-surgically, you'll probably get your crutches that you need to bring with you if you're going to have some kind of manipulation of the knee. And I think if you remember, Megan said yesterday that under the age of 5, they always give crutches, and then over the age of 55, they'll give walkers. You just need to give instructions on how this is going to, what they will be getting after surgery, what the expectation is. And then after surgery, we want to have physical therapy and occupational therapy help us learning to walk with those assist devices. And we want to have that all set up before the surgery ever takes place. So expected interventions immediate post-op after a total knee replacement is to, one, take vital signs and check the IV site, check their pain level, check their knee dressing. We want to keep that joint cold to vasoconstrict the vessels and minimize the amount of edema that accumulates. We will want to apply anti-embolism stockings, and yes, you can put those on and then still have them on when the patient gets on the continuous passive movement machine, the CPM. We want to be sure, because they went into surgery for a lengthy surgery, they were inserted a Foley, so we want to remove that within the first 24 hours after surgery. We want to monitor for hemorrhage. Now, when we were talking about hip surgery, knee surgery, it could happen with back surgery if there was a long I'm losing it, people. I'm losing it. Rod. That was a hard word, wasn't it? Gosh, it's going faster all the time. Okay, so if you had a rod inserted in the back, then there may be a drain in the back. But we've got to monitor that for hemorrhage. And so if there's a drain inserted, if there's more than 250 milliliters in an 8-hour period that has drained from the incision site, then we need to notify the physician. It should diminish to less than 25 mils within 48 hours. So we just got to keep an eye on that. So we also want to monitor for infection. We want to monitor for thrombophlebitis. We want to monitor for pulmonary embolism. We want to monitor for fat embolism. We want them to start their ambulation the day of surgery or the day after at the longest. We want to support the joint with an ACE wrap. We want thigh-high TED hose if we're going to put on compression stockings, and then elevate the leg as much as possible. Okay, so there are certain signs and symptoms that we want to look for within the first 24 hours that are that can be critical. First of all, we want to watch for atelectasis. We have stressed this over and over for post-surgical patients, is because the person has not turned, cough, and deep breathe for for several hours because of surgery, then they're going to potentially have or start to develop atelectasis. So we need to work on our pulmonary toileting, and I refer you to the conference for that. All right. Guidelines for total hip replacement. We don't want the person to cross their legs for 3 months. We want to keep their legs abducted. We don't want to bend the hip greater than 90 degrees. I think I said less than in the lecture. And that didn't make sense to me at all, because less than is what you want to do. So I think I made an error in that. So you don't want the hip angle to be more than 90 degrees at a given time. So this will affect you sitting. This will affect you going to the bathroom. This will affect you bending over. This will affect you doing many things. And I'm just going to pause you here for just a minute. So I had an interruption. Do you know why? Let me just show you. Yes. Looky here. There you go. That's that. Then I had this. Yes, and then what else I got? I got a pen. Oh, there you go. Pen. This is from 5 years of service at Davis Technical College. Actually, it's been 6.5 that I've been at the college, but the first 1.5 years I was working as a Weaver instructor. Yes, I was. And then, I get $75 at the bookstore if I buy something with the Davis logo on it. Deal. And then I got a check, but I'm not going to show you that. It's not huge, but I will take whatever I can get. I'm not above that, people. Yes, it is 5 years. Got to tell you, 6.5 years. 6.5 years. Here. I don't have a tissue, so I'm not going to cry. Anyway, so let's get back to where we were at. I don't even remember where we were at. Let me look at my notes here. Yeah, let's see. Oh, we talked about that. We talked about that. Okay, so we were going over guidelines for total hip replacement. Do not cross the legs for 3 months. Keep the legs abducted. Do not bend the hip more than 90 degrees. And don't bend the body forward. Don't bend over to pick up things. Do not rotate the leg when standing. Keep the leg straight. Let's see what else we've got here. Keep the surgical leg straight when changing positions, and use a toilet extender. So, complications that you want to look for is a dislocated hip, and you may ask yourselves, well, what are the signs and symptoms for a dislocated hip? Well, the person's going to be in severe hip pain. That's a fact. And then they're going to have a shortened leg, and they may have an internal rotation of that hip. So, when you are going to discharge a person after they've had a hip replacement, then you want to tell them, don't cross your legs, use this toilet instead of a bedpan. And again, you may need to get a toilet extender. Stand without bending at the waist, and no heating pads. And boom! I think that's it, people. I think that's it. Yes. And I just will send the force to be with you next Monday when you take this exam. Because why? Because you're going to rock it. All right? Have a great weekend. Have a fun, just titillating clinical too. All right? All right. See you guys later. Come by and see me. Make an appointment if you need to. And my poor cursor won't let me log out. Oh, here we go. See you. Bye.